Looked at the exams, and I looked at 4 categories here. People that increased a lot, and there are like 3 or 4 of you that increased a lot, and about 20 points. There's about 12 of you that increased between 10 and 15 points, something like that. About 12 of you that increased, that stayed the same. But the really positive news from my perspective is that none of you declined. So from the first exam, so that's good. So now, for those of you who are running in place, so in other words, those of you who got this last exam, the same score as this exam, right? I think you're still, the way I look at it is you're studying harder, but you're not studying hard enough to improve your grade. Right? If you were studying as hard as you were for the first exam, this exam would not have been pretty. So I think you're taking it more seriously. It's just that you're not taking it seriously enough. For those of you who are doing well, keep up the good work, and I'm very pleased. Yes.
What would you say is like a good score? An 80? Maybe a good score.
So that's all personal preference, right? So for what is your preference? What is your definition of good? Is someone else's definition
Well,
of
I'm
good?
just wondering based
So-
on your.
No, so I'm not going to sit here and say, oh, this is, because I have former students. I remember a former student of mine, former teachers said to me, we don't think she's going to pass, but because all her testing scores are really, really low, but she works her ass off, man. It's crazy how hard she works. And she did very well, so I think she got a C+. That was an awesome grade for her. So I'm not going to sit here and say this is a good grade, this is a bad grade. Right? I can tell you what grade it is, and whether or not you're improving. So I can also tell you that this unit is significantly harder than the last one, just like I said before at the start of the semester. So get ready for changes. We're doing joints and articulations today, and then we're doing muscles afterwards. I have a minor schedule change that we'll talk about in a minute. But in terms of this week, we have lab this week, and we're going to do something different this week. We're going to start doing an experiment on electrophysiology of muscles, and we're also going to do joints and movements. There is no, so listen here, there is no mini practical this week, okay? So there's no mini practical, even though Juliana said to me she wanted one because she liked it so much.
So when's the mini practical? 24th or 25th?
So
Next week?
next week there will be a mini practical, and it will be on muscles, and we will be using whatever the hell her name is.
It's not on the articulations?
So
Because in the lab handbooks and.
So I will get to talking about the next mini practical because of the changes, the schedule changes. So October 23rd, which happens to be my son's 20th birthday, I'm going to be the only one in this room that is maxing and relaxing because everyone else in this room is taking the SAT. And the best thing about this is that I can't be there. I got locked out of planning for the SATs, so I was like, don't tell anyone. So I had to change the schedule on that a little bit, so I'm trying to figure it out. And I'm trying to keep, as best I can, trying to keep the lab and lecture together so that we can keep in sync. In terms of what we're doing today, we're talking about chapter 8, and that's joints and articulations. And I'm going to do a drawing with my laptop, my iPad, and talk a little bit about some notes here. So in particular, there's 8 or 9 pairs of movements that I'm going to talk about. We're going to talk about different types of joints in this class today, and I want to talk about one joint in particular. This is chapter 9.
Chapter 9 or chapter 10? Okay. I don't know. Because she's.
All right, so first thing we're gonna talk about is we're gonna learn a pretty significant vocabulary today and start using that vocabulary. The vocabulary is gonna be based on the anatomical terminology that we've already been using. So there's a lot of overlap between what we've done in the past and what we're doing now. And remember too, that when we talk about movements, when we talk about these articulations, when we talk about all of this stuff, it's all based on starting with anatomical position. So without anatomical position, we are lost because you can't tell me what movement is what without understanding or without remembering that. So in terms of, we're gonna talk about 3 types of joints. And I'm going to write the prefix 3 prefixes. So there's syn, amphi, and di. So there's syn, amphi, di, syn, amphi, di, syn, amphi, di, and these are the structures of 3 different types of joints. Here, all 3 terms have the same suffix. That suffix is called arthrosis, and that gives us our first clue as to what we're going to be talking about today. Arthrosis, or those are articulations. So there's synarthrosis, amphiarthrosis, and diarthrosis. Of the 3, the one I'm going to be talking about today the most is diarthrosis. Is there a question? In terms of the types of movement here, there's no movement in synarthrosis. And by the way, so I'm just gonna copy this. So there's no movement in synarthrosis. There's some movement in amphiarthrosis. And there's free movement in diarthrosis. So free movement means if you can move your shoulder around, if you're ever walking around and you see me with Ms. Campbell, so last year she had her shoulder surgery, and I would go to her and I say, give me a high five, but I make her do high five with her right hand, because she can't do this. And so why can't she do that? Because of her lack of interest in physical therapy. But that inability to do that is an example of of the movement that your shoulder has, and that's got a particular type. That's an example of free movement. So there's syn, amphi, di, synarthrosis, amphiarthrosis, and diarthrosis movement. When you're talking about the joints themselves and articulations here, we have tendons and ligaments. Does anyone know what the difference between those 2 are?
I know one's bone to bone and one's muscle to bone.
So one is bone to bone and the other is muscle to bone. And when we talk about muscle, we're going to talk about skeletal muscle to bone. So which is which?
Isn't tendon bone to bone? I could be wrong.
Switch around. Ligaments are bone to bone. And the way that I remember it, a long time ago, is the Achilles heel. Achilles is at your calcaneal tendon. That tendon attaches to a muscle, a big muscle in your calf, and that attaches to your calcaneal bone, your calcaneus. And so that always, it's easy for me to remember it that way. Tendons, so it's bone to muscle. So bone, when you're talking about bone to muscle, you're talking about the next topic in our discussion, which is the structure and the naming and the activity of those muscles, of those skeletal muscles. Now, in terms of the muscles themselves, when we talk about the muscles themselves, they're going to talk about different types of movements, and I'm going to talk about 9 different types of movements, or give you 9 different types of movements. Bless you. And by the way, I want to say one more thing. I said that diarthrotic movement, joints, diarthrotic and the term synovial are very similar. They're slightly different, but they're very similar. Diarthrotic and synovial joints, and I'm going to tell you what a synovial joint looks like in a minute, has 6 types of joints. So we're going to focus on these 6 types of joints. And if you just consider the knee versus the shoulder, those bones can do different things. If you tried to make as much movement in your knee as you do in your shoulder, that would be pretty painful. And it would happen once, and then you'd have to call 911. So the knee isn't built to do that, and so it's classified as a different joint. Let's see here. So now what I want to do here is to talk a little bit. Oh, wait a minute. Before I do that, let's talk about movements. When we talk about the movements, and these are diarthrotic or synovial joints, they're paired terms, and these paired terms are some of the things that, one of the examples of the quiz that we're going to have next week in the mini practical, I'm going to ask you, what would this muscle do, and what type of movement would it make? So would it make this movement or that movement? Would it make another movement or this movement? So that's another thing that we're going to be talking about here. But in terms of the movements here, they're paired terms. And the way that I look at it is that if I know one, I don't have to know the other. Right? If one, almost to a word, to an example, except for one case, these are, if you move one way, it's one thing. If you move another way, it's a different way. So the first one is flexion and extension, abduction, and hopefully Ms. Voyage and Ms. Minardi talked about some of these. This third one that I'm going to put a little star here, these are not exactly the same. I'm classifying them as paired, but because it's easier that way. These are slightly different. But for right now, they're rotation and circumduction. Sometimes these terms have specific joints or articulations that it occurs at, and there's only one thing, one place. For instance, pronation and supination is a version of rotation, but pronation and supination only happens in the forearm. So if you go like this, if you move your hand one way or the other, I'm going to grab my coffee and I'm pronating slightly so that I can drink. Pronation and supination only happens in the hand. Hold on a second. Sometimes these words are pretty easy to understand. So pronation and supination are weird. elevation and depression are just opposites. If you ever say something mean, you want to take that back. You might want to retract those words here, and so that word retraction is you're bringing the bone back to original position. Opposition, reposition, again, bringing the bone or the bones back to the original position. And the last one, the last of this pair is plantar flexion and dorsiflexion. So these are the list of terms or the paired terms of descriptions of movements that we are going to be using. And the question will be, from anatomical position, what direction am I moving? What direction am I moving? Right? What direction am I moving? Right? And what is that description, right? So that's going to be that. Then the next level of questions would be how taking the muscles that we're going to be discussing and talking about what the muscles do, because as you know, all muscles do is contract. So that if I'm going like this and I'm standing on my tippy toes, that's one example of movement. It happens to be dorsiflexion here, and plantar flexion. So plantar flexion here, so that movement right there can be described by the gastrocnemius and the soleus contracting. So then the question will become, what is the movement that produces plantar flexion? Is it this muscle or that muscle? Or what muscle produces this? And so there's a number of different ways that we can ask that question. So there's a lot of stuff there in terms of the terminology, but I want to go back to this one right here, the diarthrotic articulation. So this diarthrotic or synovial joint, and in particular here we're going to talk about the structure of a synovial joint. And I want to end my drawing with this in mind here. So a drawing of a synovial joint. We're going to begin by just drawing the parts of two bones, and we're going to label it using the terminology that we've already labeled or we already used from Unit 2. So there's going to be some overlap in the terminology, and if you don't remember the Unit 2 terminology because you're in Unit 3, that's going to come back to bite you. So first of all, let's see. So there's two bones that come close together, but they don't touch. This bone right here, and that bone right there, are labeled in a particular way. What are the ends of bones called? So it's not, it could be a diaphysis, but it's not. What is it?
Distal epiphysis and proximal.
So there's distal epiphysis and proximal epiphysis. So if we just talk about this being the knee, then the one on the bottom will be the proximal epiphysis. Proximal to what? Proximal on this bone. So that's closer to the point of attachment, and then conversely, this is the distal epiphysis. The diaphysis is up here. And then there's going to be 3 layers of tissue here. There's 3 layers. There's an outer layer, there's a middle layer, and then there's an inner layer. So I'm going to draw in three different colors here. So there's an outer layer, and I'm making it really obvious right here. Different. So that outer layer is continuous with the bone, and it's going to merge with the bone, and I'm trying to make it so that it looks exactly like it's meant to. It merges exactly with the bone. It's completely connective tissue. So there's that. Then there's, let's see here. Then there's another layer right here. And then there's the red area right here, and then I want to go back to the blue. And there's also blue at the end of these bones right here. So we have this area that's occupied by the red space. We have the blue area right there, and then we have the black area. The blue area, the blue line right here, and then there's the blue at the end of each of the bones, the distal epiphysis or the proximal epiphysis. So in terms of the blue itself, we're talking about, here, wait a minute, yeah. In terms of the blue itself, this is called articular cartilage. In terms of the black, oopsie. This is called a collateral ligament. And the collateral ligament just does it. It helps stabilize the bone, but it doesn't move the bone. This entire structure is not going to provide any force to move. It's just going to provide the ability to produce less friction so that the bones don't smash into one another. There's the There's two layers deep to the collateral ligament. There's a fibrous layer of the synovial joint, and then there's the red layer. And that red layer has a couple of different terms here, and I'm gonna put those all right in here. Oops. So the synovial membrane is the red line. There's also synovial fluid that is found inside the cavity there. And there's also the synovial, the space itself is called a synovial cavity. So when we have the synovial membrane, I'm going to tell you in a minute, the synovial membrane is the portion of this articulation that specialized cells that releases material, and it releases fluid into this joint. That fluid is called synovial fluid. It's a cousin to the blood plasma. That's where it gets all its material, its proteins and stuff like that. It's not blood plasma at all, but it's quite different. And it basically keeps this bone, the distal epiphysis and the proximal epiphysis, from smashing into one another. This dual layered structure right here either the fibrous layer or the collateral ligaments here are basically keeping the bones from moving in this direction and opposite direction. And then the articular cartilage is keeping the bones from smashing into one another. And if you smash into one another and you get, if I asked you guys to just do this for 5 minutes, how many people could rub their hands together for 5 minutes? I'll give you a ride in my Bentley if you can do that for 5 minutes. Why is that going to be a problem? Friction. Well, there's 2 problems with that. Friction, what's friction going to do? What? So now if you do that over decades, what's going to happen here? Right? That's going to degrade the bone. Now, you want to know what the other problem with that, me giving you a ride in my Bentley? I didn't drive my Bentley today. I drive one of the other cars today. So I couldn't give you a ride in my Bentley anyway today. There's no other problem with that thought, is there? So this is a pretty simple drawing. This is called a synovial joint. So a synovial joint has synovial fluid, synovial membrane, synovial cavity. It's an example of a diarthrotic joint. There's 6 different types of diarthrotic joints or synovial joints. Oops. And so these are some of the objectives that we'll talk about today. So when we talk about these synovial joints here, right, this diarthrosis is these terms are almost the same. They're not quite the same, but they're almost the same. Okay? So are there any questions for me? So now, just so you know, so today is Wednesday. So next Monday, I'm going to do a big drawing of muscles. And we're going to start with a bone. Here, I'm already started trying to practice sketching it. It's not that I don't know the material, it's that I'm trying to use this damn thing and make it reasonable. And this next drawing is probably going to be 2 or 3 pages worth of drawings. So it's going to be pretty significant. And it's got a lot of vocabulary. So this is a pretty straightforward drawing, and we're going to start in a lecture right now. On Monday, the only thing we're going to do on Monday is do a drawing. Right? Typically, when I've done it in the past, I might have, if I were going to do this, if I were to make everyone move over to the one side, I could start over here, and I might be able to finish it over there, in a very, very bottom corner there. So there's that much drawing here. So there's a lot of terms. Right? So the other thing that I want to say is that just like we did last time here, we have 3 main topics here. So in this case, we have joints and articulations. Then there's muscle tissue, and then there's the muscles. Last time, we had the skin, bone tissue, and the bones. After the skin and the bone tissue, we had a quiz. After the joints and articulations and the muscle tissue, we're going to have a quiz. All right? So I'm going to show you what the schedule is. I posted the schedule already, and I changed it. So let me just change devices right here, and I will switch in a second. So I will post this online later today. And
Do you have a different colored pen? Yeah.
So if you guys look at this schedule right here, this is on announcement on Brightspace. It also is reflected in the syllabus that I changed. This is, today is the 16th, laboratory 6th. We're going to do a combination laboratory where we do a little bit on joints and articulations and then some muscles. So we're going to do a 2-part lab. We're going to finish up that second part of the lab in laboratory 7. And then while you guys are doing that, you're going to have a practical. So there's 2 things going on there. Notice here next week, next Wednesday, there's no class here, so don't come here. And I'll be here, maxing and relaxing, but you guys need to be taking SAT. Monday, October 28th, we're gonna have a quiz. That quiz is on chapters 8 and 9. We're doing chapter 8 today. Next week, we're doing chapter 9. We're spending 6 hours on chapter 9. So one of the things the way that I make this class easier, which might sound stupid, but it does sound crazy. I could do this whole muscle where I spend 6 hours on this, 2 lectures. I could do this in 50 minutes. Would I mush over some things and go fast and just tell you general stuff and then have you figure out yourself? Yes, it's exactly how I do it. So I could go over maybe 50 minutes, maybe 2 50-minute lectures. So in other words, a sixth or a third of the classes is how I would teach it if I was teaching down at URI or somewhere else. So I want to just continue on with this lab here, or this schedule rather. If you look at the bottom now, again, this is posted online. So next week, October 28th is quiz. Then we have 3 sets of muscles here. There's the axial muscles and appendicular, pectoral girdle, and pelvic girdle. There's a lab, and then the following Monday, November 4th, is exam 3. That exam 3 is going to have the same structure as exam 2. It's going to have 25 questions on what we're talking about today, 30 questions on the muscle tissue, 30 questions on each of the pectoral and the pelvic. Oh, I'm sorry, 30 questions, 15 questions, and 15 questions. The other thing about these muscles is, remember now, all of these muscles that we need to know, they're already on the list. But for the name of each muscle, and we'll talk more about this next week, you need to know the name, the origin, insertion, and the action, and then also the location. But definitely you need to know 4 things for each muscle. So there might be in a muscle, say the occipital frontalis, or the gastrocnemius, the pectoralis major. So you need to know where they are, you need to know their name, but then there's also the origin, insertion, and action. So there's a lot to know. The actions, or what they're moved, or how they move the body, is what we're talking about today. So any questions about this schedule? Okay. And again, this is all posted in this Unit 3 schedule. That's right here on the front page of Bio 220. So in terms of the joints and articulations, you've already heard a little bit about what I'm going to tell you in a minute, right now, and that's sort of some of these learning outcomes here. The muscles and the articulations go together, right? So one of the things that I spend a little bit of time on is these first there's 3 different types of articulations that I told you about, 2 of which don't move very much. So those are not going to be a terribly interesting. When you start classifying joints, there's 2 ways to classify them. There's structurally, what type of stuff is found within the joint, and we can talk about synovial joints, cartilaginous joints, fibrous cartilage joints, and then we can talk about how they function, or syn, amphi, di, arthrosis, syn, arthrosis, amphi, arthrosis, diarthrosis. Syn, amphi, di is the way that we'll talk about, we'll focus more on it, but we'll talk about it in the context of the structure of each of these joints. So whether they're fibrous, cartilaginous, or synovial. So let's talk about the fibrous, and let me back up one thing. So I'm going to tell you in a minute here that these joints are all based on what's present in a synovial joint or a diarthrotic joint. So they're based on that. So the context is the fibrous and cartilaginous joints don't have a cavity, and I'm going to tell you that in a minute. Synovial joints do have a cavity. So therefore, synovial joints are freely movable, and the other 2 move, one moves a little bit and the other doesn't move at all. Little to no movement are fibrous joints, and you need to know the bones that, the types of bones where they meet. In this case, there's no joint activity, there's no joint cavity, and there's no movement here. The bones are connected by fibrous connective tissue, and there's 3 types. There's sutures, syndesmoses, and gomphoses. There's weird words, but you don't need to know much about them, except you definitely need to recognize them. So we'll just talk. So the first of those 3 sutures here are pretty straightforward here. You already know some of the sutures in the body. The way that we describe them now is that opposing bones interdigitate. Now, what does that word mean? Digits are fingers here, and by the way, this is my favorite finger, if you ever remember that, right? So the fingers or the bones interdigitate, so that if you take make your fist and you put your knuckles between one another, that's an example of them interdigitating. This is another way to describe them interdigitating, the 2 hands interdigitate. So that's what the 2 bones do, the bones of the skull. If you look at the sutures of the skull, they are sort of wavy. And because they're wavy, that's called interdigitating. Remember too, that periosteum is the superficial layer of bone, and the periosteum of one bone is continuous with the periosteum of another bone, as opposed to those different periosteal structures here, if they're on different freely movable bones, they're not continuous. And when they're not completely developed, they're called fontanelles. There's a couple different ways to spell fontanelle. So it's enough, sometimes you might see there's 2 L's in this word, but a fontanelle is an incomplete joint structure. And it is present during childbirth, and it allows for easier childbirth, but it also it's also found in newborns and toddlers up to about 18 months. So those fetal skulls here's some examples of fontanelles here, be it the sphenoid fontanelle, the anterior fontanelle, there's a posterior fontanelle. Those are 3 main fontanelles, and I think those are the ones that you needed to know last time. They're the ones that I can still ask you about this time, because they're in the context of this joint, this type of joint, or in this case, this is suture. Another example of a fibrous joint is a syndesmosis, and there's 2 examples of that. The examples here, there's the interosseous membrane, and you know that there's 2 examples of interosseous membrane, when there's 2 bones are parallel, radius and ulna, and the tibia and the fibula. In this case here, they're not really created equal. One moves more than the other. Which one moves more than the other? The radial ulnar is more mobile than the tibiofibular. But for right now, they're both examples of syndesmosis. And gomphosis are ones that can be completely innocuous with no movement. If there's any movement, that can be very, very painful. If there's ever anything problem going on right about here, that could be very painful. This is an example of a gomphosis. There's a tooth. There's that superficial enamel that is very, very hard. And then there's the deeper layer right here of this root. And then there's blood flow and nerve flow. So why, if you get a cavity, does it hurt? Because you have nervous tissue that is sensitive to this, to that invasion. A number of years ago, I had an infection in one of my teeth, and the dentist drilled through the hole. He drilled through the top, and his words, he's sort of a gross guy. He drilled through the top and he goes, "Oh, we got a gusher. Here, let's get some suction here." And later on I said, "What was it?" He goes, "All of that pain that you had in your jaw, all of that discomfort that you had for months here, that was an infection, and the infection didn't have anywhere to go. So the infection, all this bacteria was building up right in here, and in this space right here where all these ligaments, these called periodontal ligaments, all this pus and infected material here it just came out, and so he packed it and gave me antibiotics and stuff." That's sort of a...
You didn't take out your tooth?
He gave me a root canal, actually. So he drilled down to the base. This is the base of the jaw right here, and drilled down into the jaw. It was on my bottom jaw, I think it was. He drilled and he put a post in it, and now now my tooth is basically just sitting there. But there are ligaments here that are connecting bones, and there's lots and lots of ligaments. So why is it hard to get a tooth out? Because these ligaments are holding it in there. So this is an example of a gomphosis. There's fibrous joints, there's cartilaginous joints, and they come in two varieties. There's synchondroses and symphyses. Of those two, the word symphysis is probably the most familiar or more familiar. A synchondrosis has some examples of hyaline cartilage. Symphyses have fibrocartilage. Synchondroses come in two different varieties here, where there's the sternocostal example and the epiphyseal plate here. I don't really talk about the spheno-occipital example. There's no joint cavity. There should be little or no movement. There's maybe some in one case, and movement in another case is a problem. If you have movement at the epiphyseal plate, right, that's a problem. Right? And I'm not saying that this is movement, right? So in this case, if I'm moving my right humerus and I'm moving in a particular way, this is abduction or adduction. That's when the entire bone is moving, right? Now, when I talk about movement here, my fingers are also movement, but they're not mobile. They're not moving at all. It's all movement at this joint right here. There's also, when I was a kid, there was an epiphyseal plate. Now there's an epiphyseal line. If we're talking about the epiphyseal plate here, if there's movement there, that means that the head and the diaphysis, or the area that's closer to the diaphysis, one is moving, the other is not. Right? That's not happening here. That is not what we're talking about here, and don't get that confused. If we have movement at the epiphyseal plate or the epiphyseal line, that's called a break in a bone. Right? That's a problem. We might have movement in the sternocostal region here, and that is normal, typical inhalation and exhalation, breathing in and breathing out, moving, you're increasing the volume of your chest cavity or thoracic cavity and decreasing, right? That's easy. So in some cases there's a little bit of movement, in other cases there's not. In addition, some of these cases here, some are permanent and some are temporary. So they're permanent and they're temporary examples there. So the temporary example would be the epiphyseal plate or the epiphyseal line. Symphyses are examples of fibrocartilage there, and we have two examples here. Intervertebral disc and the pubic symphysis that I'm particularly interested in. The manubrium in the sternum is not an example that I'm terribly worried about. One example when you have movement of the pubic symphysis is during childbirth, where that articulation actually separates, and that separation comes with a little bit of pain, or so I'm told. So this is why it's classified as slightly movable. There is no joint cavity right here, and you're basically taking fibrocartilage that moves two bones, or that unites two bones. So the fibrocartilage just continues between the adjacent bones, and we talked about slip discs or damaged discs already in the last unit. So the intervertebral discs are also examples. I could give you an example of let's say the L5 and the S1 intervertebral disc. That happens to be where my daughter has problems with her back. So that's pretty much right where my red pointer is. That intervertebral disc is a problem for her. But in this case, that fibrocartilage is an example of a symphysis. All right, so that gives you a little bit of a setup for the talking about synovial joints. You already know that those synovial joints have this fluid called synovial fluid, and there's an awful lot of mobility associated with them, and there's a lot of complexity there. It's much more complex than other joints. There's articular cartilage. Have we talked about that? Yes. There's a joint cavity with a capsule, and that capsule will have a fibrous capsule, and that's that, I think, the blue layer right here. And then the synovial membrane is an inner layer, and that's the red layer that I drew. That fibrous capsule is dense connective tissue, and that's going to be helping, that's continuous with the periosteum. And that's just, we're not worried about whether or not it thickens here. The deeper layer here is the synovial membrane, and its function there is to release synovial fluid and to provide a little bit of structure. Synovial fluid is a complex material. I said it's derived from plasma, and it is, but it is this slippery material, and it's got a mixture of a lot of stuff. If you've ever heard of someone that has water on the knee, if they got damaged knee and they drained it, literally the osteopathic person or a surgeon would stick a big needle in there, remove some excess fluid, and hopefully relieve some of the pain. That fluid there, it has a combination of proteins, fats, polysaccharides, and is very slippery. It's meant to be, it's not water, but it's meant to be basically keeping these two very, there's a lot of pressure on these two bones.
So it's basically a lubricating fluid.
And it's a lubricating fluid that prevents the bones from hitting each other. In addition, there's also, later on in the semester, this last term here, this last topic, nerves in the capsule will help your brain know where your joints are, so that you can go and I can reach around and put my hand in my left pocket, my right hand in my left pocket. There's something Miss Campbell can't do. So I put my left hand in my right pocket, or my right hand in my left pocket, right? So I know where my joints are. I don't have to say, oh, I'm gonna be putting it in here. I can do that automatically. I know where my body is, so the body position. And that's helped with the particular aspect of the brain. So these synovial joints have some complexity associated with it, and here's another version of it. Here's a different drawing of it. We have the superficial, no, wait a minute here. In this case, we don't have this drawing right here. So we don't have the collateral ligament on this drawing. So in this case, I just have this picture right here. It just has a fibrous capsule, and then there's the deeper membrane here. That's the synovial membrane, but there's also going to be ligaments, that additional structures. Here. Now, that synovial membrane here is going to be, this is the red area right here, where my red dot is the cavity itself, and that cavity contains synovial fluid. The area that is superficial to the bone that tries to keep the bones from smashing into one another. They come in a couple of different names here. There might be the term labrum, there might be a meniscus, but the general term is articular cartilage. If you look on the left-hand side of this drawing, there's also tendons and tendon sheaths. Once again, we talked about whether or not there's ligaments or tendons here. Now, in this case, this tendon is going to be going, because of its name, it's going to a muscle here, and it has an external sheath right there, and that sheath, I'll talk about that when we get to the muscles here. We'll talk, it's called a retinaculum. That sheath is going to be continuous with that superficial layer, the collateral ligament. In addition, there's stuff that I didn't talk about. There's stuff that I didn't draw. I had enough trouble drawing that as it is. There's other structures, accessory structures here. So accessory structures, in particular, there's little pockets of synovial fluid here, and these things are called bursar sacs. The bursar sacs, if there's an inflammation of it, it's called bursitis. Bursar sacs are little areas that help maintain where the blood vessels and the nerves are, and it keeps accessory structures stable. It doesn't keep the joint itself stable, but it keeps other things stable so that there's more mobility and less pain. In terms of the things themselves, the stability here, so we talked about ligaments and tendons. They serve very similar functions, not the same, but very similar functions here. Sometimes that articular cartilage that I just mentioned comes in a couple of different varieties. I mentioned there's a meniscus, the plural of which is menisci. Meniscus is something, another example would be labrum, and then a final example would be articular discs. Sometimes those three things will come in these specific joints or specific articulations. And then finally, there's also going to be some examples of fat pads that are there. Basically, again, trying to keep everything straight, keep everything organized. So let's talk about the different types of joints themselves. When we talk about the joints themselves, some of them are very complicated, have lots of mobility, others of them do not. So if you go like this, and once again now, who's the guy that, is it John Cena that is there's a wrestler that used to do this, right? So now if you look at this movement right here, my hand is moving, right? But it's because my shoulder is moving. Right now, so in my and in particular my humerus, okay? So now, if I go like this, that's one example of movement. This is another example of movement. Now, if I move my elbow, and I'm just talking about my elbow movement, and I move it, this is what's called uniaxial, occurring around one axis right here. If I move it this way, and it's just my humerus doesn't move, then I have problems right here, and I'm breaking my joint, my elbow. So that doesn't happen. So that's called uniaxial. Biaxial here would be an example would be this, where there's multiple axes here, and then multiaxial would be an example of your shoulder. And sometimes I've seen some books talk about the hip. And the hip is really multiaxial too. In terms of the joints themselves, there's 6 joints. There's plane, saddle, hinge and pivot, ball and socket, and ellipsoidal. Ball and socket come in 2 varieties, and they're easy to remember here. There's shoulder and hip. So let's just go over those 6 types here, and then we'll take a break. So in terms of the 6 types, so this is a plane joint, and the plane joint comes in a couple of different varieties. And if you look at where I have these table right here on the left-hand side, they include this plane joint, there's an intervertebral, a acromioclavicular, and then carpal metacarpal. Just look at that term, that last one, carpal metacarpal joints. Where are those found? Right? So look at the name, there's carpal and metacarpals. So there's the proximal surface of the metacarpal and the distal carpals. Right? You can't have the proximal carpals and the metacarpals joint, right? So there's carpals and metacarpals. So the point here is look at what the name means, because many times these words will tell you something. Other examples here: intercarpal bones, sacroiliac, intervertebral. Makes sense, right? Once again, these terms there, which ones am I going to be most likely to select? These 3 examples that are in bold. So a plane joint is uniaxial. There's not a lot of movement around here. So the acromioclavicular joint, the AC joint, which is right about here, there's not a lot of movement there, but there is a little bit of movement because there's so much mobility in your shoulder. This is a saddle joint, and this saddle joint here, one example of that is sternoclavicular. That sternoclavicular is the manubrium and the clavicle. There's a little cutout there. That little cutout, again, is allowing for the movement of the shoulder. Classic hinge joint is either the knee or the, I'm not going to use the word elbow. I might, but I'm not. I can use the word cubital region. The antecubital region from quiz 2, the antecubital region is anterior to the elbow, so the cubital region is the elbow. In both cases, they're hinge joints here, and they're uniaxial. So the knee and the elbow, or the knee and the cubital region, are uniaxial. If you look here on the right-hand side, in terms of the knee, last unit we talked about the knee joint having 3 bones, and in this one, the femur and the tibia is just discussed here. In part because as a hinge joint, the patella doesn't really move. The patella is pretty much stationary, and it's the tibia that's moving, pulling the fibia along, and the patella is the one that's allowing for the smooth movement of the tibia. Right, so that's why the tibia and the femur are part of the knee joint and not the patella. Pivot joints they're rotational joints, and the atlantoaxial joint, whereas the atlas and the axis, and then the proximal radial ulnar joint. Not the distal, but the proximal radial ulnar joint. That's a pivot joint. Ball and socket joints are multi-axial. There's 2 examples I mentioned a minute ago. There's the glenohumeral, the shoulder, and the hip. And then some ellipsoidal joints. There's the metacarpal phalange joints. So the metacarpal, the distal metacarpal, and the proximal phalange. That's biaxial. You can move them in a couple different ways here. And atlanto-occipital. Again, that's the joint. That's the atlas and the occipital bone. So don't get too worried about, there's going to be lots of exceptions to these absolute rules that I'm telling you. Now, I'm trying to give you just sort of classic examples of these, and I'm going to focus on those classic examples. There's definitely going to be times when there's things that don't happen. In terms of the movements themselves, we can have different types of movement, gliding, there's angular movement. Angular movement will change the angle. Here's one example of changing the angle, going from anatomical position. They're 180 degrees, now it's 90 degrees, now it's less than 90 degrees. That's changing the angle. There's abduction and adduction, rotation, pronation, supination, right? All of these things are things that I just mentioned in the previous review there. So after we get through this part right here, then we're going to stop. We're going to give you guys a break, let me walk around, and then we're going to pick it up some more. So flexion and extension are these are opposites here, so that if you're talking about anterior to the coronal plane, that can be flexion. Posterior to the coronal plane can be flexion, unless it's not. Okay, so posterior to the coronal plane. So the coronal plane is this, right? And this is saying extension right here. But if you look at this drawing right here, this picture here, there's a couple of different examples here. I want you to particularly look at this and this. So why did I underline it? Because I want I want to illustrate the exception. So flexion from anatomical position. Flexion is definitely true. Anterior to the coronal plane. Anterior, definitely true. Extension, posterior to the coronal plane, moving it away from or back towards the coronal plane. Now, here's another example of flexion. My foot is flexing, or my tibia is flexing. Is that anterior to the coronal plane? No. Right? Posterior to the coronal plane? No. That's anterior to the coronal plane. So my point here is that the arm and the leg, they definitely undergo flexion and extension, but they go opposite to one another. And so that is something to focus on. So that description right here is true for some things. This is from the book. This is true for some things and not for the knee and the foot. Examples of just moving the foot here. There's two sets of paired terms. There's dorsiflexion and plantar flexion. Plantar flexion is standing on your tippy toes. Dorsiflexion is walking around on your heels. When you move your arm away from anatomical position, you're not adding to the body. When you move it back towards anatomical position, if I'm like this and I move it back towards anatomical position, I'm adding to the body, so that's adduction. This is abduction. And then the same thing is true with hands here. So remember, anatomical position is when your hands are like this, right? So that this is abduction, this is adduction. Now, in that case, we're worried about the midline of the hand and then also the midline of the body. So for the hand, we're worried about moving it back towards my favorite finger or away from my favorite finger. The arm itself moving away from the midline of the body or back towards the midline of the body. Adduction towards the midline of the body. Adduction towards the midline of the structure or the hand. Rotation. The one example of rotation that I will focus on more because I'm trying to separate movement of the humerus when I get to it. The rotation is movement of the head. So that is an example of rotation. And there's medial and lateral rotation. If you're in anatomical position, you're already medially rotated. So in order for me to be in anatomical position, to do medial rotation, I have to go lateral rotation first. So there's lateral rotation and then there's medial rotation. And once again, I won't worry about that with the humerus. I won't worry about that with the humerus because the humerus has this example right here, it's circumduction. The near ability of, once again, not for Ms. Campbell, the near ability of your shoulder to move in 360 degrees, it certainly moves as a cone. That glenohumeral joint is really a combination of a number of different types of movements. And so rather than say flexion, extension, abduction, and adduction, rather than saying this right here, we just call it circumduction. I mentioned earlier about the movement at the elbow here. Now movement at the wrist. There's pronation and supination. If you're in anatomical position, the only thing that you can do is pronate your hand, and then if you want to move your hand, return it to anatomical position. That's supination. A number of years ago, I was in physical therapy, and my physical therapist and I were talking about movements and stuff. And she said, "Oh, I always remember it because I want a cup of soup." And so I want the soup, and so I grabbed a cup and I asked for the soup. So there's that movement right there is for supination. And then the other one is pronation. And so now let's talk a little bit about some of these terms here called special movements. Elevation and depression, the example of that I will do there. Oh, wait a minute here. Wait a minute. Elevation and depression, I thought I had the mouth opening. I don't use the shoulders as shrugging here. I talk about the jaw. So in this case, the jaw says the mandible can move forward and back, or protracting and retracting. It's not really. I'm not worried about this one, but up, open, and close. Open and close. Open is depression. close is elevation. So it's elevation and depression. And that's the one that I'm gonna more focused on with the jaw. Protraction and retraction, I'm not as worried about. One thing I will talk about when we get to the muscles themselves, there's muscles on your head there and your jaw that are associated with closing your mouth. Those muscles are not associated with opening your mouth. There's other muscles that are much, much smaller that are inferior to the mandible that basically pull on the jaw and open the jaw. They depress the jaw. So there's elevators and there's depressors. Those elevators do not depress. Those depressors do not elevate. Here is the elevators and elevation and depression here, opening and closing of the mouth is what I'm going to be focused on. Opposition and reposition, again, is got to do with the thumb. Right? One of the reasons why we're so unique as animals here, humans. Not many animals in the world have thumbs, and we can do this. Right? And so the example here, now there's more than one example, right? We're going to just say the pollex and phalange number 5. That's an example of opposition and reposition. Inversion and eversion there. Inversion is twisting your ankle. Eversion is turning it out. So eversion is walking like a duck. Inversion is twisting your ankle or turning it medially. And there's a couple of different ways, examples of sort of problems with joints. And there's 3 examples here. So when there's complete removal of the bone from that cavity. So for instance, in the shoulder here, you can have a dislocation. So in physical contact sports, so rugby, football, soccer, sometimes there's examples of dislocation here. That shoulder then gets popped out off. Most of the time that shoulder, if it gets dislocated, will pop anteriorly. And then you see like in the movies and stuff, someone will pop the shoulder back there. Like they push on the back and they push on the shoulder and the thing pops back. Don't do that if that happens. I go to the doctor. So that's an extreme example here. So the prefix sub, where my pointer is, partial dislocation, that's pretty much oftentimes pitchers, baseball pitchers. They're throwing the ball 100 miles an hour. Well, at some point, your arm has to be generating that much force. So your arm, your humerus in particular, is going a hell of a lot, very, very fast. And it's really not built to do that for any length of time. Once or twice maybe, but hundreds of thousands of times, that's a problem. And so that might cause a subluxation. And then we talked about stretched ligaments here, are sprains. One example of a sprain is example is the ankle. All right, so I want to take a break right here. It is 9:42, so let's come back at 10 minutes, 9:52, and then we're going to go through selected joints and talk about some of the articulations, and in particular, we're going to focus on the ligaments associated with it.
Y'all saw the email Ms. Benny just sent?
About the tendon thing.
No, my email. She sent one like at 9:30 about the mandatory last day of SAT prep.
Not up for debate. Mandatory.
I gotta go and then I gotta rush out of school to get to my home.
Oh, really? I'm not into that stuff.
You should have access to it.
Look.